So we're going to talk about the panel methodology and the analysis. Dimitri's going to talk about that. I'm going to talk about the results as well as the recommendations from our advisory board for next steps. Let me just start by saying that this process was really designed to see could we have identify a methodology by which we could actually have a large number of stakeholders involved in this prioritization process beyond what is typically done, which is in meetings or conference calls. You have a small number of advisors that might be participating in your decision-making process. We really wanted to see, could we have a scalable process where we could start with a large number of advisors, like 350, but potentially scale to thousands of people so that we get true stakeholder engagement. So that's why we use this methodology. So, Dimitri, we're...
Obesity, heart failure, Kawasaki disease. Within the first two conditions, conducted panel. The first panel consisted of patients only, then the second was clinician only, and the third was mixed panel. And the mixed panel consisted of researchers, clinicians, as well as patients. And for Kawasaki disease, we conducted two panels only. One that consisted of patients only, other one was mixed. So within each panel, the participants used the same protocol. We used the same data collection protocol. Across all of the panels, across all of the conditions, participants used the same rating criteria to provide us with, next slide, please. So what we've done here, we wanted to know what kinds of goals or what kinds of ultimate outcomes are we looking at. So to identify what we call aspirational goals, we worked with older advisory boards mission to identify these. And so for weight management, that was decrease the proportion of adults that are obese by 10% by 2020. For heart failure, it was reduce unwarranted hospital readmissions for heart failure by 25% by 2020. For Kawasaki disease, it was to reduce the percentage of new Kawasaki disease permanent disability by 1/4. Besides helping us identify aspirational goals, advisory board members nominated research topics that could be conducted. These topics could be conducted to help us achieve aspirational goals. Next. And so all the panelists in our panels used the following 5 rating criteria. They've rated each candidate research topic, each one of them using 9-point Likert scale. So the first was informed decision making. How helpful will successful completion of projects on this topic in fostering more informed healthcare decision making by patients and their caregivers? The second criterion was collaboration. How helpful will successful completion of projects on this topic be in fostering collaboration among patients, caregivers, and clinicians for efforts to improve health? Next one was relevance. How relevant will projects on this topic be to a large proportion of caregivers? Impact was the next one. How effective will projects on this topic be if implemented correctly in achieving the aspirational goals? The last one, how creative or new will projects on this topic be in addressing the aspirational goal below? So instead of simply asking them to rank order projects, we wanted to get a more nuanced information from participants because we hypothesized that some project may have high impact on a very large number of patients and caregivers, but what is it exactly? How does that impact? How can it be achieved? Is it through facilitated collaboration or informed decision making? So we were not sure. So to different ideas. So how did we do that? We conducted a series of round elicitation, online expert elicitation processes in ExpertLens, which is a modified Delphi system that Rand developed earlier. So when participants were randomly assigned to one of the panels, and when they logged in, they would provide their numeric response, a scale from 1 to 9, and they would explain using open text boxes as to why they rated a particular research topic, or high or low. Before they did it, they reviewed the background information that presented evidence, that explained what all the terms meant. We wanted to make sure that both patients and research, all participants, including patients, actually understand what we're asking them to do. And then, so in the second round, we showed them how their individual response compared to that of the group. So we showed them on the chart that you're seeing, the red dot is their own response. Yellow bars, the height of the yellow bars determine the number of participants who chose each response category. The line is the median. The shaded gray area is interquartile range. So it really tells participants where their opinion is in relation to that of other participants. And as you can see, they could review the rationale comments given by all participants, respond to a rationale comment, or initiate a discussion thread. So, and the discussion boards were moderated by the same moderator in all of the panels that we've done. Next slide. Finally, in round, students were able to revise their original round 1 answers in light of group feedback and discussion that took place in round 2. And they shared their thoughts on their participation as well. So how we analyze the data. Well, as you can imagine, we got a lot of data, so we had to make some decisions and go through steps to make sure that we capture what people told us. So right now I'm focusing on how we analyze quantitative data. So we've used, the first thing we wanted to do is for each question that we asked, we wanted to see whether participants within each panel, whether they disagreed or agreed with each other. So the first step was to determine the existence of disagreement. And to do that, we've used the randomness method for analyzing expert panel data. And according to this method, if you have a third of your participants in the upper tail and in the lower tail of the distribution at the same time, there is disagreement. So on the chart that you're seeing right now, that's an example of disagreement. You have 35% in the lower tertile, which is response categories 1, 2, 3 on the 9-point scale, as well as 8% in the upper tertile, which is responses 7, 8, and 9. Such a distribution automatically produces disagreement. So and the decision in this particular case, or the group decision in this particular case, is that there's uncertainty due to disagreement. If there is no disagreement, right, we would then look at the value of the median. And if the median falls in the upper tertile, according to the Range-UCLA appropriateness method, that's a positive decision, meaning that participants agreed that in this particular case something is feasible. If the median was in the lower tertile, it would be group agreed that something was not feasible. If it's in the middle tertile, that's an uncertain decision without disagreement. So for each question that we asked, once we determined the group decision for each rating criteria, we looked across all the questions that we asked within a panel, calculate the percent of positive decision. Positive decision meaning that the group agreed something was feasible, impactful, innovative, and so forth. Then we've aggregated across the rating criteria to determine the average score for each topic. As a reminder, we asked 5 rating criteria for each topic, so we wanted some kind of a composite score. Then, based on the composite score within each, we identify the top 3 topics with the highest overall mean value across the 5 rating criteria. And then we focused on these top 3 topics within panel, and we wanted to see how many topics had positive decisions on all rating criteria. So once we've done that, we then looked at the highest overall mean values across all rating criteria in all panels. Because not only did we have multiple topics, multiple panels, we needed to kind of have to look at the results across topics and across panels within each condition. And and then Kathy will tell you about our findings a little bit more in detail.
All right, so here are the results from our panels. So we hosted 3 condition panels, sub-panels within each, as you can see. So weight management and obesity, we had 121 participants in the 3 panels. Heart failure, 112, and in Kawasaki disease, 116. So it's a significant number, a substantial number of panelists participating in this process. We had a very good retention rate, so both heart failure and weight management obesity panels had around 67-68% retention, and that means the people who started, the experts that started in round 1, also completed round 3. Kawasaki disease was our stellar panel. We had 97% response rate. Yay, Jane. So I'm going to go through each condition and give you a sampling of the results. So for weight management obesity, this is the % positive decisions within each of the panels. So for clinicians across all topics, across all criteria, they had 69% positive, patients were 84%, and the mix were 91%. So we have a really high level of consensus, and we have a high level of positive decisions about the topics that were presented to them. So these are the actual topics. So for weight management obesity, there were 9 topics that we started with, all nominated by our Stakeholder Advisory Board. The 4 topics were the lowest ranked in terms of mean score are these. So you can see that there are 2 topics related to bariatric surgery and 2 related to medications, one being antibiotics and one being medications. So these were the lowest ranked across all the panels. So for the other results, we will focus on the top 5 topics. So these were the top 5 for weight management obesity. What you're seeing here is the topic. Here's the topic. Here is the rank by each of the panels. So where you see a number 1, that means that was the top ranked project by mean score by that panel. So topic 5 was the top ranked for the mixed and second for patients, whereas topic 9 was the third ranked topic for all 3 panels. So that's by mean score. The second way that we looked at this was the % positive decisions. So what the cells that are shaded are the ones that have had full agreement and were positive decisions. So just by looking at the highlighting, you can see that most of these top 5 topics, there's great consensus across most of the panels on this. And then the third step was to look at the highest, or look at the mean score now across all panels. So the highest mean score was for topic 5. It got a 6.98 out of 9. And then the second, tied for second, were topics 6 and 9. So you can see here, just by the words in bold, these topics were really around lifestyle change, support for lifestyle change, barriers to lifestyle change. And the last one is a specific comparative effectiveness one around support by peer groups versus support by healthcare teams. So you could see there's a theme here in what all of the panels are really saying are priorities. It's about lifestyle change and support for lifestyle change. Here are the results for heart failure. Again, starting with % positive decisions. So both the clinician and the mixed panel were moderately sort of in line, about half positive decisions across all topics and all criteria. Patients were completely aligned, 100% positive decisions across the board. So again, the 2 lowest ranked topics for heart failure were lifestyle change and medications and other supplements and vitamins. So different kinds of results than you're seeing for weight management. So here, instead of doing the 3 slides, I put everything into 1 slide. So you can see that the top ranked topic for both clinicians and patients was understanding care coordination and how it impacts outcomes. It also had the highest mean score across all 3 panels. Second was topic 5, which is balance between patient-centered outcomes and the patient effort required to achieve them. The third highest score was effectiveness of remote monitoring and telehealth. What I want to point out here is topic 7, which is one of the potential observational studies, which is really looking at data that we might have in pSCANNER for predictions of deterioration in heart failure. And that got only a top 3 ranking from the patients. So it got a number 2. Discussion for the advisory board, whom we presented these results to, asked us to look at what are the differences in priority for different criteria and for different stakeholder groups. And so since patients are often left out of the decision-making about research priorities, they asked us to emphasize what patients think the priorities should be if there's a reason that we need to balance these decisions. So in this case, I didn't show you the data, but we also looked at statistical differences between mean ratings between the different stakeholder groups. Topic 7 is one where there's a significant difference between patients and everybody else. And so if that's the case, then this is one that we should be focusing on as a priority because there was such a difference between them and the other panels. Third condition was Kawasaki disease. So again, a moderate level of positive decisions. So patients and mixed were similar, though, 62% and 64%. Here we only had 7 topics, heart failure and Kawasaki. We started with 7 topics. So for Kawasaki disease, the lowest ranked topics were around education and lifestyle change. And here are the top 5 topics. So topic 6 and topic 1, you can see that patients, they were completely reversed. So topic 1 had patients ranking it first and mixed panel ranking it second, and topic 6, you had the reverse, patients ranked it second and mixed panel ranked it third. But they're the 2 highest mean scores. Interestingly, on the data that we didn't show, both of these topics had significant differences in ratings on different criteria, and they were, again, exactly reversed. But that means that if we were to look at both of these, that we've sort of covered everybody's priorities by picking these 2 topics. So that was some of the balancing that we were trying to do. I'll point out also that topic 7 here, again, was a potential observational study. I'm sorry, look at the wrong one. Topic 4 is potential observational study. This is algorithms looking at EHR data to see if we could identify possible cases of Kawasaki disease. So that was another one that ended up being a high priority, but just not as high as the other 2. So what are our recommendations? So we presented this to all of our advisory boards. So we had 46 members of our advisory board arrayed in 4 different advisory boards, 1 focused on governance, 3 that were focused on each of the conditions. So we brought all those advisory boards together in 2 webinars and presented these results. And we summarized the feedback that they gave us from both of those meetings. So for weight management obesity, the recommendation is that we really focus on multi-pronged interventions focused on lifestyle change and support by peers and healthcare staff. So even though this doesn't cover every one of the top priority topics, the discussion really was identified that many of the top 3, but still lower ranked, could be components of a lifestyle change application or a lifestyle change intervention. And so by focusing just on those 2 highest priority topics, we'd sort of cover some of the other issues. For heart failure, the number 1 topic was care coordination, and it was a clear priority across all of the panels. So it's recommended that we go forward with that one. That topic 4, even though it's a priority, those kinds of things, telehealth and remote monitoring, are likely to be parts of an intervention around care coordination. And so even though that wouldn't be the only focus, that we might address some of those issues by focusing on care coordination. Again, topic 7, the factors in deterioration, it was recommended that we make that a priority because of the difference between the patients and the other panels, and the fact that the patients identified this as a priority. And for Kawasaki disease, the 2 priorities are medications and diagnostic tests, and that if we were to do a 3rd priority area, that it should be the algorithms for detection of cases in the EHR. And that was the only observational study that made that priority list, so the others would be interventional studies. So those are the recommendations that they made. So we have, they also made a couple of analytical suggestions. So one, as we complete the analysis, that we really look at, as Dimitri mentioned, we randomize patients and clinicians between the panels. And so we look at, for example, patients that were in the patient-only panel and patients in the mixed panel and see if their ratings were different, not just qualitatively, but were their actual ratings different. So we will be doing that analysis. And then the other analysis that's in progress is qualitative analysis of the discussions. One of the things we're interested in is why people make different decisions depending on which group you're in, whether you're with your own stakeholder group or whether you're in a mixed group. And part of the way we hope to answer that question is to look at the actual discussion threads and to see what kinds of questions or comments are made, who responds to who do people pay attention to in that discussion. So we hope to tease that out with the qualitative analysis. In our next phase, phase 2, which starts tomorrow, we will be having co-design teams that take these priorities and actually develop research studies to address them. And we will write grant proposals if those are needed. If we can do the studies without additional funding, we will try to do that as well. We hope to spend a year designing the studies, submitting grant proposals, and hopefully we'll be doing several of these studies in years 2 and 3 of phase 2. So, of course, we have to acknowledge everybody that's involved in this process. We had a huge team that was really, really wonderful to work with. So 46 members of our Stakeholder Advisory Board, that should say 349 members of the Research Prioritization Panel, and then the engagement team from many of the pSCANNER sites that met every week to really pull this process off. So I'll take any questions that you have. Thank you.
Does this pretty much follow what PCORI would recommend for patient engagement? Is it open-ended and you can?
So we think it does.
Okay.
We're writing a methodology paper about this whole process in which we actually map all of the work that we did in stakeholder engagement in the prioritization process, but also in our governance against the PCORI principles of engagement to show how a comprehensive engagement strategy could be implemented. So we think it maps very well because we've actually fulfilled every one of those principles in multiple ways, and we want to demonstrate that. I think the value of having done this online Delphi consensus process is that we had a really rigorous methodology for how we came to decisions, both with quantitative analysis and qualitative analysis, that then had a feedback loop, right? We did it with the panel, but then we went back to our advisory board because a consensus process doesn't give you the answer. It gives you a guide for making the answer, and then someone has to make the decision. So we went back to our advisory board to make the final decision. So we think we've demonstrated that sort of whole cycle of engagement to get to prioritization decisions. Thank you.